I'm thinking about centering an IOL in patients who have pseudoexfoliation or weak or loose zonules, especially in the setting of a trifocal IOL. It's really important that you're taking care to not damage the zonules that are working or not to create any additional trauma. So it's really important that your technique is pristine. Whether you're doing a divide and conquer or chop technique, you want to really minimize stress to the zonules. But once you've taken out the cataract and you've got a clean bag, it's incumbent upon you to recognize whether it's time to put it in a capsular retention ring or not. So if I have some zonular weakness, sometimes you'll see that at the time of making the rhexis. Sometimes you don't notice it towards the middle or end of the case. But if you notice it, sometimes you'll see some striation, basically connecting the clock hours. So if you see a vertical line in the posterior capsule connecting the clock hours, that's a sign you've got some zonular weakness. So if you see that, it's very important that you're putting in a capsular retention ring to stabilize the capsular bag. And if you don't have enough zonular support, it's important that you're comfortable with either putting a lens in the sulcus or using a Ahmed segment where you're fixating a ring to the sclera. But once you have either a capsular retention ring in the eye or you've fixated the bag, putting it in a multifocal IOL becomes pretty standard, just like a regular IOL. I think the haptic design of a lens can also be important, and the C-haptic works okay, but you can also get some striations that sort of connect the dots between the ends of the haptic. So haptic designs can play a role in centration, and obviously zonular stability is super important to make sure that you get a nice centration of your IOL. During cataract surgery, you have to be very careful making sure you're not damaging zonules or losing integrity of the capsular bag, specifically the posterior capsule. If you don't have an intact capsular bag and you try to implant a lens in the bag or even in the sulcus, it can lead to lens tilt. Likewise, if you have any zonulopathy or zonular damage that's caused during surgery or from a pre-existing trauma, that can lead to lens tilt, which can be problematic, especially in all lenses, but more specifically a multifocal lens. When we have lens tilt in a cataract surgery, what happens is the lens starts inducing coma and aberrations like astigmatism. As we know, to get a good outcome in a trifocal lens, you need to minimize coma, pre-existing or iatrogenic, and also minimize the astigmatism. So you really want to make sure that you're not having a great deal of lens tilt. And so if you're worried or concerned about lens tilt, you need to either put in a capsular retention ring, or if it's zonular in origin, or consider other technologies, because trifocals will not necessarily be the best choice if there's zonulopathy or lens tilt from other causes. The study that Dr. Gupta and I performed on arcuate incisions and low corneal astigmatism was really a passion project. We were talking, we're colleagues, we were talking about our outcomes and our approach to taking care of those patients who don't have astigmatism that would be at the level where a toric lens would be indicated. And we came up with what we thought were best practices. We developed our own formula to determine the appropriate length of the arcs and the arcuate axis. And we basically did a study that compared patients who did not have arcuate incisions. So that would be our control, our standard patients. And they had to have basically between about a quarter diopter and 1 diopter of astigmatism. And then we compared that to patients who had femtosecond laser cataract surgery with arcuate incisions using our proprietary formula, the Wӧrtz formula. And what we found was that there was a statistically significant increase in the amount of patients who achieved 20/20 uncorrected vision postoperatively in the treatment group compared to control. So patients who had arcuate incisions with our nomogram or formula had a 1.8 times increased chance of having 20/20 vision or better uncorrected postoperatively, and patients had a 3.54 times increased chance of 20/25 vision or better. So when we were designing the study, what we were trying to do is really talk about the value proposition of arcuate incisions, specifically in patients who would not qualify for a toric, and see whether or not it made an impact on visual quality. And we determined it really did. All of those were statistically significant. And we also launched a free website, lricalc.com, to help surgeons if they want to use our formula to do that free without charge. And patients are benefiting, surgeons are using it with great success. My top tips for LRIs are to use the femtosecond laser if you have access to them. A femtosecond laser provides unprecedented precision in terms of the arc length and the depth. We can use corneal imaging and very specifically determine the depth based on the percentage of corneal thickness. So with a femtosecond laser, we really have the ability to titrate arcuate incisions within 1 degree. We can put them exactly on the steep axis using iris registration software, for example, with the LensR Ally product and others. And so really a femtosecond laser is fantastic. I may be a little biased, but I would also say use a nomogram or formula that has been validated. There's a number of them that are out there, so doctors can do their research. We have our data published, so lricalc.com. If surgeons are new to using arcuate incisions, it's a great place to start. Surgeons may decide they want to tweak it or do a little more or a little less, and that's fine, but that's maybe a good place to start. The other pearl I would say is don't go too big. Don't use one of the older formulas without modifying it, because we have had some doctors in their early experience using formulas that were meant for manual incisions at the limbus, not on the cornea, and doing larger arcs maybe beyond 50 degrees, 65, 70, 80 degrees, and that can actually induce ectasia. And so you obviously don't want to create a problem, you're trying to solve a problem with astigmatism. So being less aggressive early on, using validated formulas or nomograms, and having access to a femtosecond laser are all great tips if you're just getting started trying to correct astigmatism with AKs. In ophthalmology, we only have a few companies that offer end-to-end portfolios where they can offer a full range of products to surgeons and surgery centers, and that can ultimately impact patients. When there's limited competition, it limits innovation and it also limits price. So ophthalmologists, surgery center managers, patients, I think all in some way suffer when there's not more robust competition and more robust innovation. So I think we all welcome new entrants into companies who are interested in offering end-to-end portfolios, because it does, it's like the rising tide that floats all boats. It actually helps all of us have more choice, more competition. That helps everybody.